Welcome everybody. Thanks very much. I see many people are joining at the moment. We're just going to give everybody a few minutes to join on to the webinar. Sorry. We'll just be putting up a slide in a moment, but in the meantime, maybe I can encourage you to introduce yourselves in the chat and let us know your name and organisation and where you're dialing in from. And whilst you are also doing that as well, you'll also see on this first slide, we're going to try and use Mentimeter through the webinar as well, see if we can make that work. So if once you've introduced yourself in the chat, maybe you'd also like to go to that www.menti.com and enter the code that's here on the slide. And there's a brief question for a poll. You will see from time to time, I can see all of my colleagues from Indlela also busy introducing themselves. We will be posting messages from time to time on the chat with instructions, so please do keep an eye on the chat box. And for those who are perhaps ringing in on a phone, it would, or connecting from their phone, it would be really helpful if you could change your profile name so that we can have your actual name, perhaps rather than Samsung16 or something like that. So do, if you can, under the participants, change your name so we can see who you are. Great, lots of people joining. And I can see lots of people signing up. We've probably got another minute or two before we get started. Anybody who's just joined, please, as you'll see, do introduce yourself in the chat, your name, which organisation you're dialing in or calling in from, and maybe which country as well. And for those who didn't hear, we are trying to use Mentimeter, so you'll see a link on this first slide. If you can go to sorry, I think I got muted for a moment. Please do go to the menti.com, and there is a single question as a poll there. You can enter that code and complete that. Great to see so many people joining here. I think we have about half of those that we're expecting to join. This is like a final minute if anybody needs to go and grab some water or coffee or something, and we shall get started, I think, in about a minute or so's time. Anybody who's just joining us, please do just sign up, sign your name or introduce yourself on the chat. And do please keep an eye on the chat throughout. Lungi will be posting various messages throughout our time on the webinar as well, just sort of keeping you updated. If anybody has yet to, please do go to that menti.com and do the one question poll. We're just going to see if we can make that work through the webinar. It's great to see so many people joining. So exciting to see so many who are able to participate today. Okay, so just a final call. We'll just give a final few seconds for hopefully some of the last people to join us. and then we'll get started. Great. So just if there are any last people who are joining us, please do introduce yourselves on the chat that you see there. If you have a moment, you can also go to menti.com, just do the final poll. And we will we'll make a start in a moment. Okay. So I think let's get going. I think it's going to be a busy and hopefully fun-packed afternoon. We will obviously, hopefully the last few people will be able to join and introduce themselves in the chat whilst we're doing this introduction. It's great to see so many of you participating today. We really appreciate you being so enthusiastic and participating in this second Indlela webinar, How to Nudge Your HIV Program to Success. I'm Sophie Pascoe, and I'm one of the local leads for the Indlela project. I'm based at Hero here in South Africa. Be interesting to see for all those who've participated in the Mentimeter poll, maybe we can just take a quick look at how that turned out. So very exciting, lots what we're all hoping to learn today. Unsurprisingly, lots of behavioral economics, so innovation, retention, nudges, that's great. And it looks like we've actually managed to make Mentimeter work, which is even better. So just a couple of admin points before we move on. We are going to be recording this meeting. The host will have currently muted your microphone for the main session, but we will shortly be going to breakout rooms, and you can then unmute yourself to participate in the discussion in those rooms. If you do have any questions at any point throughout the presentation, please can we ask that you type those in the chat, and we'll either try to answer them in the chat or live if we have time. If we don't have time to get back to you in the chat today, then we will follow up with you via email and respond to your questions as well. So without further ado, I am going to hand over to Harsha Thirumarthy to take us into the first part of the webinar. Thanks. Harsha.
All right, thank you so much. Sorry for that brief technical difficulty. Great, I hope you all can hear me. 1 second. Great. So yeah, thanks so much. Once again, I just want to reiterate what Sophie and others have shared. Just delighted to see so many of you join us today. And also, you know, this was the first time we tried the Mentimeter, and it was actually very illuminating and useful for us to see what all has brought people here today. So, and also I'm relieved that we actually will talk about many of the things many of you typed into the Mentimeter today. So my name is Harsha Thirumarthy from the University of Pennsylvania, and I'm going to kick off the first part of this webinar with a very brief introduction to set the stage for what Indlela is about and how we seek to work with many of you who have joined us today. So Indlela, as I suspect a lot of you are aware of what Indlela is about. We've been up and running since January of this year. We represent a collaboration between the University of Pennsylvania, the Health Economics and Epidemiology Research Office at Wits University, as well as researchers from both the Boston University as well as University of Cape Town. And with support from the Bill and Melinda Gates Foundation, we have set this up with the objective of building capacity to both develop as well as evaluate various inexpensive behavioral interventions or nudges, if you will, within the context of HIV service delivery initially, but over time, more generally in health service delivery in South Africa, and ultimately the goal being to improve health outcomes. And specifically the objectives we have are to increase knowledge and awareness of key insights from behavioral economics among researchers and implementers in South Africa, and then to see that knowledge translated into action by actually supporting projects that would evaluate interventions that are informed by behavioral economics. You'll see more about this later, but you can follow us on social media and also sign up for the newsletter if you haven't already. So as for the agenda today, well, let me just tell you about the team. So you're going to hear from many of us today and interact with us, and we have and we've built in several opportunities to have more dialogue between those of you who've joined us and the Indlela team. So I won't do an introduction of each and every person, but you will get to hear from us today and in the future as well. So the agenda for this webinar is as follows. I'm going to do a very brief introduction of behavioral economics and why we think it has relevance in service delivery in South Africa and HIV prevention and treatment more generally. With webinars, I suspect is not the first webinar that you've joined since the COVID lockdowns began. So we want to make this interactive, and we want to have a lot more dialogue between those of you who've joined us and the Indlela team. So we'll have some breakout rooms in which we'll focus on a couple of very specific behavioral economics concepts and collectively think about how they could be applied to HIV service delivery. That will go for about 20 minutes. And then we'll come back to do what we're calling a design sprint, which is essentially an illustration by Indlela team members of how theoretically one could apply behavioral economics concepts to design interventions within HIV service delivery. And to make it really concrete, we'll focus on a specific behavioral challenge, which has to do with promoting linkage to care. So following ART initiation, how do we ensure that people stay in care over the short term, especially? And then finally, we want to make sure we set aside time to talk about what's next. So beyond these types of webinars, we really want to see more implementation of behavioral economics work in South Africa. And so we'll tell you about these behavioral insight tests, which are projects Indlela seeks to support both with technical support as well as financial support as needed. And an upcoming virtual workshop series. Okay, so with that out of the way, I will just give you a brief introduction for what motivates Indlela and why we started this. So I think as many of you would recognize, with all of the biomedical advances in the past decade or more, there's been remarkable progress in combating HIV in South Africa, but also in sub-Saharan Africa more generally. And with the advent of these biomedical interventions, we've seen a number of targets that countries and UNAIDS has set to ensure that these biomedical interventions are being accessed and used by people, both on the treatment side as well as the prevention side. And of course, the two are linked as well. So while that's very encouraging, and these targets have really animated much of the work that's happened, from our perspective, human behavior still presents what we would think of as, or what we would call, a last mile challenge to ending HIV. And what we mean by that specifically is that even when services do become available, they don't necessarily get utilized at the high levels that correspond to the targets that have been set, for example. So you see this in the progress towards the 90-90-90 targets, or increasingly the fast track 95 targets. And also, if you break it down specifically, you can see that either on the provider side or on the patient side, there are behavioral factors that impede these types of behaviors along the cascade from being achieved. So that, in some sense, motivates the behavioral economics perspective that Indlela seeks to promote. And we recognize both at the team from Penn as well as our team members from South Africa recognize that this is obviously a field that has exploded in the last 15, 20 years, reflected by a lot of popular books as well that have drawn attention to why it can be helpful for understanding the way humans behave. And so behavioral economics, for those of you who may not be familiar with the field, essentially is a discipline that is bringing together a number of insights from both psychology as well as economics. And it's using those insights to both unpack why people are not behaving in a certain way. And then I think importantly for us, it's also using it to develop interventions that can help achieve the desired behaviors. And so those behaviors that I just mentioned, we're going to focus on that in Indlela. A couple of examples. It's obviously very hard to do a full survey of the field, so I just want to illustrate a few examples of how this has been used. And if I can just, for some reason, I'm having trouble advancing the slide. Okay, maybe I'll ask Caroline if. Actually, Caroline, do you mind advancing the slide here, please? And for some reason, I'm having trouble with that. Okay. All right. So the first example here has to do with social norms and how they've been used to promote behaviors. So let me just once again see if I can get this to work again. Apologies. All right, so, all right, here's one example that hopefully will resonate with those of you in South Africa. Water conservation is something that was on the top of mind for many people, particularly last year. And one study that has been done in the US, a very, very well-known study in behavioral economics, had to do with figuring out how you can get people to conserve water, and in this case, among guests staying at a hotel, they're trying to get people to reuse their towels. So if you've ever stayed at a hotel, you've probably seen a sign like this. And the standard message in this randomized trial was a message that's kind of familiar or similar to what we see often in public health as well, which is to say, like, encourage people to do the desired thing, in this case, reuse their towels. And so they put a sign up and said, like, please reuse the towels. That's going to help save the environment, et cetera. And then a second approach was to say, well, people are really influenced by what the social norm is and what they perceive to be is the norm in the community, so to speak. And so in another set of hotel rooms, et cetera, this is the intervention arm in the randomized trial, they had essentially stated what the descriptive norm is on the sign. So the sign looked like the other one in the control group, but it also added the fact that, look, 75% of the guests who are asked to participate in this program are actually reusing their towels. And so it's saying that the norm in here is to reuse the towels. So what did that do? Amazingly, when people were told that the norm is for people to reuse their towels, it increased participation in this program, and it did so. The effect there was quite sizable, considering how light touch, so to speak, the intervention was. So I bring this up as an example in part because I would like those of you who are here today to both see the potential for these types of interventions to change behavior, but also perhaps reflect on where else you may have seen such an intervention. How might you envision something like this being used in HIV service delivery? That's the kind of thing that we would like to do as we engage with implementers and researchers in the years ahead. But I also want to just, in the spirit of making this interactive, encourage you, if you think of an example that you like this that you've seen elsewhere, or if you can imagine a potential application that you think would be interesting in HIV service delivery, feel free to put it into the chat box if you would like. So moving on to another example, I want to talk about the power of default settings in healthcare specifically. So the first example that probably comes to mind for many of us has to do with opt-in versus opt-out HIV testing, and I think we all can appreciate the quite sizable effect that switching to opt-out HIV testing had on take-up of HIV testing in many clinic settings, for example. So in some sense, like, I think we all are, even if we don't recognize it, we're sort of very familiar with how some behavioral economics ideas have been translated into action even within HIV service delivery. But I want to give you a different example here, which was done within the health system at the University of Pennsylvania, specifically by our colleagues at Penn. And here the goal was to get physicians in the hospital to start prescribing generic medicines rather than the branded medicines. And it's one reason why healthcare costs are so high in the US. And so before any intervention was done, you can see that generally speaking, the prescribing of generics was not nearly as high as we all wanted it to be, which is close to 100%. And for many drug classes, the prescription rate for generics was quite low. So what the researchers did in this study is, working with the implementers, in this case the health system, is they went into the electronic health records and changed the default settings to be to make it more to be biased towards prescribing the generic. And so if you wanted to prescribe something other than generic, you had to click a tick box and then type in the other alternative medication. And what that did is it significantly increased the prescription rates for generic medications. And so again, an illustration of how a relatively small change to the environment in which these types of decisions are being made by physicians, in this case, led to an important change in outcomes. So again, an illustration of this type of work happening in various different settings. In one case, in hotels for energy conservation, another case for prescription decisions in the health system in the US. So briefly, before I conclude, I want to just think about, well, how might this be applied to HIV in South Africa? There's a number of different examples. There's been work that's been written on reviews as well that has been done of how these behavioral economics insight may be or have been applied to HIV in sub-Saharan Africa. But I want to tell you briefly about one study that several of us at Penn, as well as our colleagues at Desmond Tutu HIV Foundation, recently completed in Cape Town. And in some sense, this is a mix of both standard approaches to communicating HIV-related messages, as well as some behavioral economics insights. And this is a rapid trial that was done earlier this year. And it displays several elements that we hope would be reflected in the types of studies that Indlela seeks to support. So here, what we were focused on was encouraging men to go for HIV testing. And we recognized that the mental model that many men in the community had about HIV testing and possibly being diagnosed with HIV was potentially outdated, in the sense that they associated a diagnosis of HIV with a radical alteration of their life in terms of what they could and couldn't do. And we wanted them to become more aware of this notion of U equals U, and of the benefits of treatment, both as a mode of prevention as well. And so the Desmond Tutu HIV Foundation has a mobile testing campaign, which goes around the townships outside Cape Town. And typically, those mobile testing campaigns are associated with, they come with mobilizers who go around the community and say, you should go and test at this. We're encouraging you to go and test at this mobile van that's here in your community today. And what we wanted to do was essentially tweak the message that they conveyed to men when they were encouraging men in the community to go to the mobile van and get tested. And we recognized that it couldn't be a super intensive intervention. And so what we did is essentially had a relatively short script, in this case, less than 60 seconds, a script that essentially communicated to the men what U equals U means and why it might, why it should make them less fearful of going and getting tested for HIV. And to learn quickly whether this was actually resulting in a change in the outcome we cared about, which was our men going and getting tested for HIV in this case, we randomized the days that mobilizers were going about the community to either intervention messages or the standard of care messages. And so it's a low-cost intervention, and we had a design for rapid evaluation. The study was halted prematurely because of the start of the lockdowns in South Africa in March. So these results are preliminary, but what you can see is that these relatively small changes to the messages delivered by mobilizers led to a significant increase in take-up of HIV testing by men. So that was an encouraging finding from this intervention. All right, so then to wrap up here, what we want to do today and also going forward as we engage with implementers as well as researchers is use behavioral economics in two ways. One is to use it as a way to quote unquote diagnose a problem, which is to say to understand why individuals, whether it's patients or providers, may not be behaving in a desired way. We want to turn to some behavioral economics concepts that may help us understand that. So this is the explaining behavior part. The second part of this, and this is more focused on this is where the behavioral insight tests come in, has to do with using those behavioral economics insights to then also develop interventions to promote desired behaviors. So we'll see both of these in the webinar today. And the next part of this webinar is going to be the breakout rooms, where we don't want to approach it with a mindset of interventions yet. We want to instead understand why how behavioral economics could be used to explain underutilization of HIV services or suboptimal delivery of HIV services if we're focusing on the supply side. So that's what we'll do in the breakout rooms. And then in the design sprint, you'll see an illustration of how we can use the insights to develop interventions. That's it from me. And so I just want to share with you a few guidelines for the breakout rooms. We've randomly allocated participants to 5 different breakout rooms. And we want the breakout rooms to be much more interactive, so feel free to unmute yourself. Don't even need to resort to chat messages if the rooms are smaller and we have a rich discussion. And we'll have the Indlela moderator essentially introduce 2 behavioral economics concepts, and we'll take each one in turn and see how they could be applied to the HIV cascade. So we hope that will give you a better and deeper understanding of the behavioral economics concept, as well as the potential it may or may not have to the specific HIV prevention, HIV behavior in the cascade. We'll stay in the breakout room for about 20 minutes, bearing in mind the time for the entire webinar. And at the end of the webinar, at the end of the breakout rooms, we'll come back to the main session for the design sprint. So again, thanks for joining and for your participation in advance in these breakout rooms. I think what you'll see now is a pop-up on the screen that will allocate you to the room. And so you might need to click on the go to the breakout room message.
And is everyone seeing that? Great. All right, so I'm just going to kind of pick up where Harsha left off, and let me just introduce myself. I'm Allison Buttenheim, also from the University of Pennsylvania. social behavioral scientist, and with Harsha, one of the leads from Penn on Indlela, and have been working on behavioral economics informed interventions, mostly in infectious disease prevention, for about 10 years. So our goal in the breakout session before we return to the design sprint is to think about applying just two specific behavioral economics concepts to behaviors of both patients and providers along the HIV cascade, again, with the goal of hitting the 90-90-90 or the fast track 95-95-95 targets. And the two we want to drill down to are present bias and availability bias, also known as availability heuristic. Probably two that you've encountered if you've done any dabbling or more extensive exploration into behavioral economics. They're two quite common ones. So present bias, as it sounds like, just refers to the idea that we are very here and now creatures. Our brains are really oriented to the present and less so to the future or the past. And because of that, we're not particularly good at self-control or foresight. And another term for present bias is impulsivity. We make decisions very much focused on the costs and benefits that will accrue to us right now, and we pay less attention, or we underweight the costs and benefits of a behavior that might accrue in the future. When we say costs and benefits, those might be financial, but they also might be time or affect or emotion, convenience. So when we think about what will this behavior cost me, it might cost me the hassle of going to clinic and standing in line, or it might be an unpleasant behavior, or I might have to think about sort of unpleasant things when I do it, and that might be a cost as well. And we fold all of those into our sort of calculations about whether this is a good behavior to do right now. Often for, especially prevention behaviors, but a lot of other health behaviors, those costs are quite immediate and they're tangible, and they might be, again, sort of unpleasant or a hassle, where the benefits are going to be often far in the future and maybe intangible and maybe probabilistic and maybe sort of hard to bring to mind. So it's pretty easy to see for many of us how that decision to exercise today or quit smoking or eat healthy food might get delayed or deferred when that cost benefit calculation is done. So in general, we make plans for tomorrow with thinking ahead to what we might want to do, but we revise them when tomorrow comes. When tomorrow becomes today, even if we plan to exercise or plan to eat healthily, we're more likely to park in front of the TV or have the cake. And that cycle is repeated. That's basically how procrastination happens. So this, for the HIV services, cascade, we can think about patients making decisions to delay or not immediately engage in a behavior, again, if it's costly and if those benefits are going to come down the pike in the future. And we're going to go for the kind of the easy, low cost, low hassle behavior right now, especially if the reward is immediate. This just makes it really hard to make future-oriented decisions. So with that, let's just focus on, a trajectory for a patient from, first presenting at a health facility or a testing site to take a test, if positive, to initiate treatment, to stay on care and eventually reach viral suppression and be tested for that. I'm seeing a chat, but I need to, there we go. And feel free to unmute and jump in, or you can again use our room chat. Where do you see present bias operating here? Where might a patient or a provider be susceptible to present bias in a way that might provide challenges for getting this patient to viral suppression? And this can be, from the top of your head, or if this is work you've done as well, would love to hear some examples.
Hi.
Hi.
This is Laura speaking. So I think definitely prior to taking an HIV test, right? Because there's sort of a delay in testing as a priority. So I can imagine that something like present bias would, or even prior to presenting at a health facility, sorry, taking, like if you're not aware that you're ill, and you don't feel ill necessarily, then there would be sort of a present bias that would deter you from actually even going to the facility to start off with.
Absolutely, absolutely. I think that's a main motivator or demotivator for not even presenting for testing. Absolutely.
Sure.
Other thoughts?
Hi, Sifiso here.
Hi, Sifiso.
My thoughts is initiating treatment in cases where now a person is just worried about going to a place where maybe their local clinic where they might be known. So they wouldn't want to be spending time, or they get that feeling that somebody knows what they're there to do, whether they're there to start treatment or not.
That's really relevant as well, yeah, related to the idea of sort of feeling well. It's hard to think about all the actions that have to be taken now when you know, your future health state doesn't feel as relevant or as immediate. Anything in that gap, you know, we know we lose a lot of folks, especially with same-day initiation between there and maybe returning for refills, especially in the COVID context. Any thoughts about where present bias might show up between treatment initiation and viral suppression?
Hi, this is Julia here. So I think that certainly sort of that gap between, as you say, sort of initiating treatment and then like going away and sort of taking that, and then if there doesn't seem to be sort of like anything pressing, the future sort of benefits of returning may not seem particularly salient or important to achieve. And I suppose there could be costs associated with going back to the facilities in COVID times of sort of, you know, would my risk or like exposure be greater by doing that? So do I really need to do that? So should I rather just prioritize my safety right now and deal with, you know, my health and sort of my treatment refill when I can and when it's sort of less scary or seems less dangerous at least?
That's Julia's point is a great reminder that these sort of crisis states or high urgency, immediate concerns of something like COVID can really crowd out any planning or future orientation that people do have. So, you know, present bias, we're particularly susceptible to present bias when we're in conditions of scarcity, what Elder Shafir and Sendhil Monathan calls scarcity, which could be financial scarcity, but also could be sort of time or just cognitive bandwidth to focus on things. Something like COVID blows through, and that's where all the focus goes. Like any attentional resources you have sort of go there, and something like a chronic medication or a return visit in 3 months or 6 months seems very far in the future and less important. So yeah, the additional challenges to this cascade that COVID-19 has presented are considerable.
Hey, Joe here.
Hey, Joe.
I wonder if it might also be applied from the perspective of the healthcare worker. I know that many healthcare workers are oftentimes trained on counseling for initiation, but given the competing priorities and the amount of pressure that's put on healthcare workers, the present bias is for the healthcare worker to kind of have a didactic approach, spend less time counseling and focusing on patient readiness. But the downstream effects could be fairly great when a patient is initiated without proper consultation or getting their questions asked. So I think, you know, the present bias exists in the healthcare worker focusing on the upfront effort that it takes without consideration of the downstream impact it would have on the individual patient to invest the extra 15 minutes for an improved counseling experience. And perhaps even later down the line at the point of viral suppression, to really make the healthcare worker see the value of taking the additional step to decant a patient onto something like a differentiated model of care like CCMDD in South Africa. It's an extra 15 minutes of work from the healthcare worker's perspective but the downstream benefits are, you know, a decongested facility and actually less work in the long term for that healthcare worker now that the patient might be decanted to a different modality. So it's just interesting to think about present bias from the healthcare worker's perspective as well.
Thank you, Jen, for bringing that perspective in. I think that's so true. Those providers are making the same kind of calculations and trade-offs in the moment, which we know is a very hectic clinic setting, many patients to see. And you're right, if an intervention is going to take a little bit of extra time now, that extra time feels like a lot, even if, as Joe pointed out, those could make for, you know, much easier future clinic flow for providers and, you know, easier treatment journey for the patients. So really important reminder that these operate just as much at the provider level as they do at the patient level. Let's bump ahead to the second concept, because it's kind of complementary, which is availability heuristic, also called availability bias. And this will, I think, resonate with people if you haven't thought about this before, but it's one of the shortcuts, the heuristics that we apply because we live in a really information-rich environment. We get a lot of info kind of flowing at us and have to make a lot of decisions. And because of that, our brains are really good, and this is a really adaptive response, it's just unfortunately sometimes maladaptive, that we just look for shortcuts or easier ways to make decisions. And one of them that we use is, if I can recall something, if I can bring it to mind or think about it, it must be important and it must be probable. Right, so we actually think that things that we can easily recall to mind are more likely to happen or are more important. So just as we overweight the present versus the future, we also sort of overweight easy to recall things. Again, a very intuitive response, like of course we do that, but it turns out to really be important for health decisions. So if we think about sort of all the information that we might access for making a good decision, if you can, let's see if I can steal remote control from you, Candace. The information that we actually use is just this tiny little piece, and it's the piece that's sort of flashy or obvious or different or new or recent. So a version of availability bias is also called recency, the recency effect. And you know, things that happen to us frequently, we assume are sort of happening frequently everywhere. Really interesting example from the US for obstetricians. Basically, if this is some really rigorous analysis that was done on many thousands of births from many different providers. But basically, if an obstetrician's previous patient had an adverse event, for example, if they'd had a vaginal delivery with a complication, that obstetrician is more likely to switch to cesarean delivery for the next patient. All else equal, right? Same sort of conditions and same decision point about whether to go for a vaginal or cesarean. Just that a recent experience of an adverse event in a patient will guide the decision for this next patient, not taking into account or underweighting all of the patient experience that this obstetrician has had and all the literature about the most appropriate treatment path, and vice versa. So if they've had a very easy delivery for the previous, a complication-free delivery for the previous patient, and this patient is having some concerns that might lead you to a cesarean, you might be less likely to have that if the previous patient experience was safe and easy. So some other popular examples. So we are really susceptible to things like plane crashes, which are very, very rare events. We all know intuitively, or we know from statistics that you're much more likely to be in an automobile accident than an airplane crash. But when there's a big crash that is in the news and involved lots of people, and there's some sort of horrible sort of images and great loss, we way overestimate the probability that a crash like that is likely. And you could ask people sort of before and after a plane crash, in the 6 months before there's a big plane crash, what's the likelihood that someone dies in a plane crash, and it's quite low. Right after a plane crash, people will overestimate that. Of course, we all overestimate the probability of something like winning the lottery, especially for ourselves versus for all other people. That's an optimism bias that we can talk about. But when we read about a lottery winner, our estimates of the chances of winning also go up, and we buy more tickets. Not rational, but a very efficient use of sort of recent information for help in making a decision about buying tickets or not. So, you know, and this is not, as I said, it's an adaptive response. Sometimes it's maladaptive, but, you know, it can be a good thing to be aware of probabilities or changes in probabilities. You know, if there's a crime spree in your neighborhood, you know, it probably is a good idea to take some different actions. But we have to think about when in a you know, a healthcare, especially an HIV journey, it might be less helpful. So let's look at the same trajectory for a patient and think about, again, from the provider and the patient perspective, where availability bias might be influencing this path. This one's maybe harder to think through. We had more present bias thoughts at the ready here.
Hi, Alison, this is Denise.
Denise?
Hi, I'm not quite sure if this is correct, but I'll give it a go.
Thank you. Thanks for jumping in with a risky answer.
I was just thinking, like, if a patient has a bad experience at a facility, say, for example, if that's when you initiate treatment and you have a bad encounter and you find healthcare workers are unfriendly, then that may serve as a barrier. You know, based on that experience, you may not go back just based on that previous encounter.
1000%. That is a great example. So when we're making a decision to, for example, return to care for a refill visit, the most recent experience, or the one we can most easily bring to mind, is going to influence that. And if that was negative, that is going to be really influential. Even if for other conditions or friends and family, you know, have had good experiences, the one that comes to mind is going to be the one that's influential. Very, very, very true. And a really good reason for us to pay attention to, you know, making visits as easy and pleasant and equitable and respectful as we can.
Hey, Allison and Denise, can I ask a question about that? Does the opposite work in the same way? Like if we promote stories of patients having positive experiences, does it have that same effect? Or do we also have a bias towards negative news or loss aversion?
Great, yeah. So we definitely do have a negativity bias. So if we're accessing recent information, the negative or the unpleasant information just has a more inherent salience, unfortunately. But that's not to say that we can't try to kind of load up the priming, right? You know, prime the pump with as much positive as we can to overcome the negative. We just finished a study, just accepted for publication, yay, in Peru, where we were trying to get parents, mostly moms, to use micronutrient supplementation powder for their infant feeding and their young child feeding. And this is not something that kids really enjoy the taste of. It's a powder, and you know, once you sort of add it to the food, most kids are like, blah. We really worked to, there's a lot of research on this, you know, this really important nutritional behavior that we want parents to take, but we really tried to bring a behavioral lens to it. And one of them was this availability bias of, you know, what happened the last time the kid was fed, or what happened with the parent's most recent child. That's going to be more influential than a brief, you know, counseling session at a well child visit when the nurse explains the micronutrient powder. And unfortunately, if that experience was negative, that's going to be more influential than like, oh yeah, it was fine with the last kid, or it was fine last night when I tried to use the powder. So that negativity bias is a really important one to bring in with the availability one. Lakotse, I see you unmuted briefly, hoping you are going to jump in.
So Alison, it's Hilton here. So one of the issues with availability bias might come in is when people have already initiated and the experience of side effects, I would imagine. Because if you have negative experiences that are related to side effects, you may be less likely to continue. Or if you hear stories or myths from other people saying, you know, it caused me to gain weight, or it caused me to do this, or it caused that, and was a very negative experience, that may, because that's most available to you and because it's negative, you tend to believe that, and that may alter your behavior.
Fantastic. That's a great one. And also I think points us to, we're going to talk more about interventions next in the design sprint, but does point us to some interventions where, you know, we want to make sure providers are telling us what to anticipate, right? You really don't want to experience side effects that no one told you about. So you can, you know, hopefully diminish the influence of those side effects on a decision to return to treatment if you've been a little bit prepared. But it also means that what you hear from others, you know, I think few of us, if we, you know, start a new medication or, you know, starting treatment for a condition, we're probably not going to tell a lot of people if it's going really well or if there's no side effects. I studied vaccine acceptance, and, you know, parents usually don't say like, hey, my kid got vaccinated yesterday and it was fine. They do say, oh, my kid got vaccinated and the kid had a fever for 2 nights and was screaming and it was so awful, and the, you know, the site on the shoulder swelled up. So you know, there's also just selection in what's available because of this negativity bias. We're more likely to share those, you know, those sort of notable negative effects. And it's exactly the same, I think, with starting medication. That also reminds me of a study we've just finished here in Philadelphia with patients who have a new prescription for antidepressants. And that's a medication where it takes a while for the effects. You know, you have to sort of build up a few weeks, really, of taking the medication regularly. And so both, I think, present bias and availability bias come in there, in that you're having to go through the hassle of taking the medication and maybe having side effects without any benefit yet. So it's kind of all cost and no benefit. And we really saw an opportunity for sort of incentives and some other reminders to make the future benefits a little bit more salient to people. And I can see using availability bias there with stories of real success with antidepressants. I'm looking at our time check here. It looks like we have a few, like 2 more minutes. Does anyone want to have sort of the last word on availability bias or present bias in the treatment journey? That was our last slide. I'm giving up remote control. Candace, you have remote control again. Anyone else? Fiona or Philip? Cheka, any other?
Hi, it's Koteka. Can you hear me?
Yes, we sure can. Thank you.
I don't know if this applies here, but the issue of dolutegravir and neural tube defects. So what we're finding is that staff are often reluctant to start TLD in pregnant women, even if they're beyond the first trimester, because there's this whole talk about risk of neural tube defects.
Absolutely. And if, you know, the more chatter there is about that, if there's a recent study that has looked at that, or even if the patient maybe has just recently been in the first trimester, there can be some nervousness, some sort of overweighting of that risk, such that you're not really applying, like the obstetrician, you're not really applying all of the evidence base. You're kind of over focused on one potentially negative outcome, maybe to the detriment of providing evidence-based care. Great. Well, I think we're going to get the little countdown popping up soon, but thank you all so much. If you have any last thoughts that you want to throw into the chat, or if these are the kinds of projects you're interested in pursuing at your organization and Indlela can be helpful, we'll be giving a lot more information towards the end of the webinar on how to engage with us for what are called our behavioral insights tests, our BIT projects. So thanks very much for this discussion, and hopefully the design sprint for interventions will be helpful.
Thanks, Alison.
Yeah, just looking to see. I think if you want, you can. If you all have your leave room button, you can use that to return to the main room and maybe take a minute or two break if you need that before our next session. I may have, yeah, there we go.
So the leave room option is on the bottom right hand side of your screen if you'd like to do that.
Just make sure you leave breakout room and don't leave the meeting. Yeah, Philip.
So one of the things I wondered about was using present bias to make patients aware of positive sort of nudges. You know, in a counseling session or in a recruiting session, to make them aware of, do you know anyone who's on treatment and how have things changed? So it's really just a 2-sentence interaction, and so that helps to call to mind something that's gone really well, and that can then nudge behavior. You know, because the present bias, often when we talk about that, the costs of finding out that you're HIV positive, of having your finger pricked, of having to walk into a venue, those are all sort of preventative present bias things. And so then, you know, if you can call to mind something that, oh, wow, actually, you know, things have gone really well for my cousin, or whatever.
Exactly. Priming them so that the positive image, the positive story or anecdote is top of mind, I think is really effective. And as you said, it's brief. It can be just like, tell me about a cousin, you know, a friend or a contact or a family member who's had a positive experience.
Yeah, and I mean, you know, you talk about light touch. That's, you know, as light touch as you, I suppose, could get.
Yes, although you have to make sure the provider remembers to do it, right? And they're complicated set of things. So we need nudges to the provider so that they can nudge the patient so that we can get people in here. All right, in 5 seconds, we're all going to disappear, but see you back in the big room.
Great. Just confirm that we've got everybody back. Super. I'll hand over to Alison.
Terrific. Well, welcome back, everybody. If your breakout group was anything like ours, we had a really interesting discussion around present bias and availability bias that took us through the cascade and looked at both provider and patient perspectives. We also ended up throwing some other biases in that were sort of complementary. We talked about negativity bias. We talked a little bit about optimism bias. So you really begin to see how kind of rich the toolkit is for getting a rich understanding of behaviors and how we might change behaviors. So we want to pivot now and talk about what I really think is the fun part of this process, which is designing interventions. And hopefully our previous discussion has really underscored why and how it's so important to get a full understanding of the behavioral barriers before you start designing. I think sometimes it's tempting to reach right into the toolkit and, you know, design an incentive or design a commitment device or design a default before knowing sort of what you're dealing with behaviorally. So just we ordered these sessions really deliberately to emphasize the importance of that understanding of the behavior. So we want to focus on a really specific behavior as we go into the design sprint. And we'll introduce Temba here, who's just been diagnosed with HIV. And because we're in sort of a same-day initiation environment, she's going to leave this visit today with her first course of meds. And as you know, as we all know, really the next important behavior is that she's going to return for her first refill visit. And we know that that's a big point of loss, of drop off in the cascade. So the chances that having left today with the first course of meds on the same day that she was diagnosed, her chances of returning to that first visit might be lower, that first refill visit might be lower than we want. In fact, in some recent sort of systematic review, and sorry, it's not a systematic review, but an analysis of a very, very large data set of routine data, up to about a third, so 32% actually didn't return to care after ART initiation. Just gonna make sure we have that. Okay. So when we do this in our behavioral insights tests, once we have narrowed the focus of our problem inquiry to a really specific, a really specific behavior, we try to frame it as sort of a how might we question. So what is the behavioral challenge we're trying to overcome? In this case, we might say, how might we reduce loss to follow-up after same-day initiation of ARTs? A really similar reframing of that same problem is how might we increase the proportion of clients returning to clinic or otherwise accessing a second supply of medication following same-day initiation? One of the reasons I like that second one is it doesn't assume a return to clinic, right? The goal is to get the patient to have the second round of meds in hand. If we can do that in a way that doesn't involve a clinic return, maybe that's an opportunity as well. So here's our second Mentimeter engagement. So you can, again, just on your phone or on a separate screen on your computer, just head to menti.com, and we have a new code for this next question here, 5405752. That's also just been thrown in the chat. And just in a few words, just try to capture maybe some barrier that Themba or another patient you're familiar with is facing in returning to clinic for that second supply. It doesn't have to be a fancy behavioral economics concept, but just literally in lay language, what might be a barrier that Themba is facing? What gets in the way for that return to clinic? And we'll take a few minutes for folks to re-navigate over to menti.com and get set up with that. Oh, I guess I can do it too, can't I? Oops. Caroline, is there anything I need to be doing on this screen to see our cool results?
Could you just click on it? They should be showing automatically.
Click where?
On the actual screen.
Okay, well, we'll come back to this. Hold those thoughts in mind. Where I want to go next with this is to turn it over to Brendan, who's going to walk us through sort of his view of how we might approach seeing barriers and attaching behavioral constructs and intervention ideas to Themba's problem.
Thanks, Edison. So one thing that comes to my mind is sort of the emotional response in and around the time of diagnosis, because we know that emotions can have quite a powerful influence on behavior. So I'm thinking again about Themba, who's offered treatment, and the thought of ART triggers a very negative emotion, sort of fear and dread. And this can create a barrier, because we know that when people have a very strong negative feeling towards something, in this case ART, they're more likely to judge the risks as high and the benefits as low. So when she starts weighing up whether to return to the clinic for a treatment, this can lead her to sort of overweight the costs and not return. So in terms of behavioral economics, the tendency for emotions to have quite a strong influence on our judgments of risks and benefits is known as the affect heuristic. We kind of let our gut feelings change our assessment of actual risks. So one thing which we could potentially do to attempt to pick a refill is to create positive associations and feelings with ART. So for example, at her first ART visit, she could be shown pictures of women on treatment, experiencing happy moments, achieving life goals, something like having a child, getting a new job, or sort of hanging out with friends. So yeah, just a couple of ideas. Thanks, Alison.
Another construct.
So yeah, something else that comes to mind, which could influence decisions to return for the ART refill is this, whether people can record examples of positive experiences of people on treatment. So here I'm thinking about someone like Tabani, who is offered treatment, and in that moment he's really battling to think about anyone he knows or any examples of men who are on treatment. And as he's having a struggle to come up with his examples, that can lead him to think that this is not the norm, that not many people do this, that it's not as important or that important. So when he comes to thinking about his treatment refill, this can lead him to undervalue the benefits and again change the cost benefit towards the cost and not going. So the underlying mechanism here is the availability bias, which we've just gone through in the breakout rooms. Something can be recorded easily. People think it's frequent and important. So one thing that we could do here is we could use availability heuristic in our favor to encourage Tabani to start to come back for his treatment. So what we could do is at the time of ART initiation, we could again show him sort of very vivid pictures of men doing well on treatment, share stories, and then he could use these so that then when he's thinking about coming back to the clinic, he'd be able to recall these examples, and that would sort of lead him to think that this is common, this is important, and might sort of help him to get to the clinic again.
That's great, Brendan. That's actually an idea that came up for us in our discussion of availability bias in the breakout room. That, you know, can you sort of prime the pump with the story that becomes the recent or available story in your head in making that decision. So that was really great. Brendan sort of went with the sort of affect and an emotional state and also availability bias right at the time of initiation that might influence that return to visit. Caroline, maybe I can have you look at sort of a different point in the cascade.
Thanks so much, Alison. So I'm looking at Thomas, and Thomas here at diagnosis has got absolutely no doubt that he's going to show up for his ART refill. And, you know, if you were to ask Thomas, are you going to show up for your ART refill? He'd be like, yeah, I'm definitely going to show up. And he's got every intention to show up. So Thomas fails to show up for this next visit. And you'd ask, you know, why would Thomas not show up for this visit if he is himself said that he's going to show up for this visit? And one reason for this, Alison, would be the cold to hot empathy gap. And that essentially says, you know, we fail to empathize with our future self. We fail to project into the future, and we underestimate the effect that one state B in this instant, our future state, will have on the influence will have on our decision making whilst we're in state A. So this usually leads us to optimism bias, or what we can call overconfidence bias. That is, we overestimate our ability to do something, and we're like, sure, we'll do it. We don't think about, well, what could happen if I'm really scared when it comes time to take, to come back for this medication, because at this point, I haven't thought about the diagnosis, I haven't thought about the medicine, but maybe when I'm supposed to come back, I'm going to be quite scared. It's my first time having to come and take these medications. So there's a lot of things that we need to think about. In order to sort of intervene and sort of close that gap between our state A and our state B, so that somebody can actually make a decision to come and show up when it's time for them to show up, we can help patients sort of move between states, close that gap a little bit. This can be done by offering counselors a way that they can help patients to make an action plan. We can have a checklist where counselors go through things, go through scenarios. Well, what about if you're scared? What about if you've got no time and you're really annoyed? What about this? And you sort of go through scenarios and you allow patients to move between states and think about possible ways in which they can actually make sure that person A or state A wins over state B. And another way we could do this is sort of have a reminder on the form for counselors to go through this with the patients. Alison, yeah, that's my take on this, and this is just great. One of the ways. Yep.
Yeah, and these two examples are nice to see how something that happens in clinic at the time of initiation might affect a decision down the road to come back. And that there's opportunities to, again, nudge providers, to nudge patients to get around that. Bruce Larson has very helpfully dug up the URL for seeing our word cloud from our barrier identification, and he's thrown that in the chat. It's just a click through that you can see. Thank you for that. That was beyond our tech capabilities today, obviously. But you can see stigma right in the middle there, fear and disclosure. I think those play into the opportunities that Brendan was talking about. Transport costs, no immediate benefit. Right now you feel well. A whole host of barriers that you all identified, all of which we could sort of go through a similar sort of diagnosis and behavioral construct identification and intervention planning. So as you explore that, let me turn to Lawrence for our last kind of walk through this problem from yet another perspective.
Thanks so much, Alison, Brendan, and Caroline. I think it came up in our breakout group kind of how interesting it is that there are multiple of these potential biases affecting the same behavior that we're trying to address. And so I was thinking about it slightly differently. In my mind, I was thinking about Sharon, who had initiated on the day of testing, and it's now 3 months later and she needs to go back to the clinic. And as she's thinking about it today, she's thinking about the fact that in order to get there, she has to take time off work. She has to take 3 taxis from her home to the clinic. And she's also worried because her neighbor is someone who she thinks might be at the clinic, and she hasn't told anyone about her recent HIV diagnosis. And so these things are kind of looming large in her present. As she's making the decision about to go, and she decides, well, actually today I'm not going to go, but I do think that I will go in the future. And this thinking and the weighing of what's happening today versus what might happen in the future, I like to think about it as potentially present bias. I think something we often say is like costs versus benefits, and it's important to kind of flag that when we're saying costs here, we actually also refer not only to economic and financial costs, but to the difficulty that we of performing something. And so the fact that she finds it difficult in terms of time or convenience to get there is a cost, and we can refer to that as a hassle factor. And so as I think about how we might want to help Sharon make a decision that ultimately is in her benefits her health, we could think about ways to amplify the benefits that would happen in the future and bring them to the present. And one of those ways might be saying, actually, we're going to send you reminders about what are the benefits that ART might yield in the future. And so it might be that you're going to have full life expectancy, you're going to protect your partner, you are going to protect any future children from HIV infection, and that's going to be sent to her. So when she's making a decision today, she thinks about the benefits, they're more top of mind. Something else that we could do is really think about taking away any of the costs that she's thinking about in the present. And so one way might be like, oh, hey, guess what? Here's a transport voucher for the HIV clinic bus that comes right past your house. You don't have to take 3 taxis to get there. Or maybe even better, how about we send you the medication straight to your house and you don't have to get on any transport? Or if you do get your way to the clinic, there's going to be a special queue for you that is going to allow you to go straight to the front because you're a returning patient and you don't have to wait with everyone else. And so those might be some ways we could kind of make sure that we are boosting the future benefits for now and we're decreasing the cost that she perceives in the moment. Thanks.
That's great. That's great, Lawrence. And thanks to all 3 of you for talking through that. You know, the reason we captured these as little Post-it looking things is that this actually sort of really captures what our prototyping or intervention design process looks like once we've understood the barriers through some sort of rapid contextual inquiry. That's basically some data gathering. We really do just hypothesize a lot of like, what are the barriers? Almost like the word cloud you all developed. What are the different barriers? How can we understand those from multiple behavioral constructs? And what does that tell us about interventions that are likely to work? And again, we're looking for sort of light touch, nudgeable interventions that are pretty easy to implement in existing clinic flow. Changing what providers do, changing what patients experience. Having heard all that, we will optimistically, with great optimism bias and planning fallacy, proceed with another Mentimeter poll and have you vote on, based on what you heard from Brendan and Caroline and Lawrence, which of the interventions they sort of threw out as prototypes you think might be most effective for our target behavior, which is increasing the collection of that first ART refill. So we've given you food voucher on collection of refill, sort of the incentive Lawrence talked about, encouraging patients to make an action plan, which was in Caroline's talk, sharing those positive ART stories, from Brendan's sort of affect heuristic, and the text reminder of the benefits of ART, which address present bias, but also some of the other constraints we've heard. So there is a new code. We will see if I'm able to see results here. Maybe I have to close voting at some point or start a countdown. Maybe I'll start a countdown. I don't know how long that will give me. All right, so within a minute till voting closes. And if all else fails, maybe Bruce would be kind enough to find our results again on Mentimeter or Caroline and throw that in the chat. I don't actually have a strong prior about what this distribution is going to look like. And you can see, given the richness of your word cloud, which is really some behavioral barrier identification and diagnosis, you can see that many hypotheses might come out of a process like this. Getting from a long list of possible interventions to a really crisp set that you might want to test is also an important part. Again, a sort of iterative, rapid, what's feasible, what can we try quickly, can we bake a couple of different prototype ideas into one intervention? That's a really crucial part of the process as well. All right, I also seem to be not revealing these results, sadly. So sad about that.
I've put the Mentimeter.
Oh, great. So Caroline's again put a link. Let's see who ended up. So the food voucher actually was #1, followed by the positive ART stories, the text reminder, with the action plan coming in at the end. We're about to have our presidential election in the US, and all you hear right now is about making a plan to vote, making a plan to vote. It's a very effective strategy. So, but you know, we could imagine a rapid trial where one of these was tested against the other, maybe you know, paired up. Some of these intervention elements could be paired up into 2 separate interventions that were trialed against each other, and we could sort of see who's right. Great. So that's our design sprint. I will stop my share and hand it back to Sophie for our wrap up.
Great, thanks very much, Alison. So let me just quickly share my screen and put that. Super. So let's get that up. So hopefully you found that design sprint exercise helpful, and perhaps you learned some new things that you can share within your organization, or even to try and incorporate into your current work. Now, in the few minutes that we have remaining, and the time has gone really quickly, we'd like to just share with you some information about ways that you and your organisation might collaborate with Indlela in the upcoming months, and also through our workshop series that we will be offering as well. So as part of our aim to build capacity in behavioural economics for HIV research and service delivery, Indlela plans to support a number of what we call behavioural insight tests, or BITs. And these are interventions that will be designed based on behavioural science principles. They should be low-cost solutions that can be easily and rapidly implemented and scaled up, obviously with an HIV focus. And we expect that these will be conducted by those who are implementing HIV programs, as well as those supporting implementation of HIV service delivery, or by research institutions in South Africa. The tests themselves may utilize either experimental or non-experimental design with outcomes that are easily measured, and they should include a learning component or an evaluation at the end of the intervention. The example that Harsha gave in the first presentation about the U equals U study is a very good example of what a BIT study would look like. And for these BITs that we're proposing here, Indlela will provide technical support for each of those projects. And there is also potential for Indlela to provide some funding and capacity support as well for certain BITs. That said, we do encourage those organisations that are able to implement these tests within their existing programs and using existing resources to go ahead and run those bits as well. We're happy to provide sort of whatever support we can. So in the forthcoming months, we will be setting up a process for organisations with a BIT idea that they would like support for to submit a concept to Indlela team. And then also to brainstorm with the Indlela investigators and associates on how that might be implemented, and apply for funding if that's needed as well. And details of that application process will follow. So in order to support the development of those BIT projects, what we're planning is also to run a series of BIT development workshops. And the aim of these workshops will be to build capacity amongst those who are attending to undertake a BIT project. The participation in the BIT development workshops doesn't mean that you have to submit a BIT project or proposal. And it also doesn't mean that if you do submit a BIT project or proposal that it will necessarily be selected. But we hope to be able to identify a few proposals that we will be able to support and can be conducted or run. But by participating in the BIT development workshops, you will hopefully then gain the skills that will enable you and others in your organisation to design and implement a BIT in the future. And the workshop series will be basically a combination of pre-recorded videos and presentations. There may be some readings ahead of the workshops, as well as interactive sessions similar to what we've done here today as well, so with the design sprint. We anticipate that will be about 3 to 5 workshop sessions with smaller groups of people, about 30 participants in the workshop. And similar to the BITs, these workshops are going to be meant for implementers and researchers in South Africa. Our hope is that we will get several BIT projects going, if not before the end of the year, then certainly early in the new year. So those that we're hoping will participate in the workshops should be part of an organisation that has a desire to address kind of behavioural barriers in the HIV cascade and in their programs. Our goal through the workshop series is to kind of help develop a short proposal for a BE test or project within your organisation. And if your proposal meets the selection criteria, then as we said, there is some potential for Indlela to provide technical support and funding if that's required. So how can you participate in the workshop? Well, because space is limited, there will be a review process for participation in the workshop series. And in the next 2 weeks, after this webinar, we will be releasing an expression of interest. You don't need to have a behavioral test idea at the time that you put that expression of interest in, but it will be helpful if you have a strong interest in BE and building the BE capacity in your organization, and some idea of behavioral challenges that you're looking to try and address in HIV programs that you're supporting or implementing. We will be limiting the number of participants per organization. Unfortunately, we can't have as many as that have participated in the workshop today, because in order to try and keep it interactive and also to allow for as many organizations to be involved as possible. But that said, we're going to have the first series of workshops, and then we will move. We will have follow-up series of workshops next year as well. And so with that, I'm going to hand over to Jackie to finish up. Thank you.
Thanks, Sophie. Yeah, we're nearly out of time, so really it just remains for me to thank everybody for your time and your energy and some of the really valuable insights during the webinar and in the breakout rooms. I hope you found it useful. I hope you've enjoyed it. And I hope that you leave here with some more kind of concrete thoughts around what challenges you'd like to address using behavioral insights, and you know, what kind of interventions you might be thinking about to try and counter these. I'd also like to thank the Indlela team of presenters and the technical team working behind the scenes for making sure this all ran very smoothly. We are going to be running a post-webinar survey, which you can access on the link in the chat. That should come up in a minute. Oh, there we go. But we'll also email you over the next couple of days, and you can do the post-webinar survey on that. Over the next few days and weeks, we will be in touch with you regarding the dates for the expression of interest and with more details and information. But if you're wanting to collaborate with Indlela, maybe you've got an idea for a great bit, and you can't attend the workshops for one reason or another, please, you're welcome to contact us. You can contact us on email, or if you've got any questions that came out of the webinar. There are going to, as Sophie said, be other opportunities for interacting with us in the future. We're going to be having more workshops and webinars and so on. So I think really the best way to keep updated with what we've got planned is if you sign up to our newsletter, because we'll put all of that information in our newsletter. And the link is on the presentation here. Also, follow us on Twitter, because that's also where lots of information comes through. We are in the process of developing our website, so that's going to be up and running quite soon. So watch this space. We'll let you know when it is available, and then you should be able to contact us also through the website. Yep, so that's it. Thanks, everybody. It's been great to meet you. It's been great to interact with you, and I hope that we'll see lots of you in the next workshop series. Take care and keep well. Thanks. Bye.